Welcome to episode 5 of Value Health Voices podcast, another Medicare episode.
It's not just another Medicare episode. It's actually an episode about an end-of-the-year ritual here in the United States. And you can count on two things: Christmas music at the start of November and a cut to the Medicare physician fee schedule.
Let's get into it.
Here we are. It's episode 5. And right now, as we speak, on the 9th of December, physicians are facing another proposed 2.8% cut to their payments from Medicare in the coming calendar year of 2025. This continues a pattern that we see year after year. To understand why this keeps happening, we're going to talk about a couple of key historical developments, a couple of key pieces of legislation that continue to impact us today. And the first one, and this is rewinding the clock a few years because it was repealed in 2015, but it was active from 1997 until that year, was the so-called Sustainable Growth Rate Formula, or SGR. And this, the SGR, regularly triggered essentially automatic cuts to physician payments. And in 2015, that's when Congress passed MACRA, and the point of MACRA, among other things, was to eliminate the SGR. And back then, people threw around the term, this is the, quote, permanent doc fix. But in reality, a second law dating back all the way to 1989, actually, even with MACRA, continues to force Medicare to propose cuts every year. And this is a budget neutrality requirement. And that's the real reason physicians, you and me, Amar, face pay cuts from Medicare every year. And I contend that it's a major reason why physicians in this country find themselves pissed off now and again, especially this time of year.
No, I hear you. And I remember the days before MACRA with the SGR when pretty much, the reason behind the SGR is there would be a target and then actuals, and it built on each other year to year. And so at one point, right before the SGR was repealed and MACRA came in, the cuts was going to be as high as 21% because it had just built year on year, and they kept kicking the can down the road. And so when you look at the SGR cuts versus what was the Medicare Economic Inflation Index at the time, the MEI, that it was completely not correlated at all. And so something had to be done. And I remember everyone was around this time of year in December getting very nervous about those cuts. And so MACRA, when it came around, people thought this is finally the answer, but it wasn't. And here we are again with another cut. And I think maybe it'd be helpful for our listeners and viewers to kind of know a little bit about how does Medicare actually set payment for physician services, to kind of then understand why it keeps getting cut. And so a lot of it comes down to this concept of the RVU, which is the relative value unit, which physicians hear of all the time, because that's what people are trying to, that's what your procedures get valued at. So pretty much everything is valued in relation to something else, hence the relative part of it. And so what's built into that RVU is the work you do as a physician, the practice expense, which is not only equipment and supplies, but also consists of your staffing, your other clinical staff are all built into it. Plus, there's the indirect practice expense, which is your front desk and your overhead and all that is built into it. Then also malpractice is built into it, and as well as different care costs differently across the different geographic regions. So there's adjustments for that. So pretty much physician work, practice expense, both direct practice expense and indirect practice expense, geographic variations, and a malpractice. All that goes together to create a RVU. And then RVU gets multiplied by a conversion factor to get a dollar amount. And Medicare sets that conversion factor. And Anthony, maybe you want to talk a little bit more about the conversion factor.
Sure. The conversion factor is the much watched number that comes out in the final rule. And the final rule, I was talking about that's released by Medicare every year in November. And we'll talk a little bit about the specific yearly timeline of events. And a lot of physicians who, even those who pay, let's say, minor attention at these comings and goings of health policy, will have some sense of this calendar as this news hits the let's say, the healthcare press. But as we look forward to 2025, this dollar amount is currently set to be $32.35. So for every RVU that is done, that is converted into a dollar amount of $32.35. And an interesting thing that we were talking about in preparing for this show is that this dollar amount of $32.35 is not that different than what it was way back in 1992, just to pick a year, when it was $31. And if we think about the $31 in 1992 and we adjusted it to today for inflation, it should be 72. But instead, we are stuck at $32.35. Incredible.
Yep, exactly. And to put it into an example so everyone can understand, let's say a doctor is seeing a patient for a follow-up visit. That has several components. There's the physician work, which is, let's say, close to like a little less than one RVU. And then when you add the practice expense and the malpractice insurance in, it comes closer to about 1.5. And then when you make adjustments for geography, let's say there's not really much adjustment on that side, you multiply that 1.5 times the conversion factor to get the dollar amount. So this year, if the conversion factor in 24 was $33, you multiply it by that, you get about, $54, give or take, is how much that service costs. So that's where that comes from. And so the conversion factor is multiplied by the RV to get your dollar amount. And so this is the issue. So the cuts we're seeing every year is because the conversion factor is being decreased, as you said, because of budget neutrality, which is this old concept that maybe you might want to explain to our viewers why do we have to keep having conversion factors reduced?
Yes. And we should also say that since we're talking about the conversion factor, a bit of confusion that I've seen brought up again and again over the years in talking to people, even people who've been practicing for years, or maybe they're managers or have some other administrative role, is that sometimes they can get confused about the conversion factor. There's only one. It does not matter the specialty. There's a conversion factor for a neurosurgeon. It's the same conversion factor for a primary care physician,
right,
as it is for us in oncology. And so, but to directly answer your question, Amar, where this all comes from, I alluded to the year 1989. And back in 1989, a bill was passed. There's these so-called omnibus bills. This is not new. This is a thing that we see again and again as to how the government is financed. But in 1989, there was the Omnibus Reconciliation Act in that year that created this situation of budget neutrality. And despite the SGR and then MACRA after that, neither of those two laws did anything to the underlying requirement, statutory requirement in the 1989 law that requires us to always be budget neutral as it relates to Medicare physician payments.
Right. So, and by budget neutral, I'm just going to really dumb it down even more. We're talking a fixed pot here, right? So Medicare gives a fixed pot of money for all the docs to carve out how they see fit. And so every year with technology changing, there may be some new procedural codes which have new RVUs associated with them. To offset the new RVUs, the conversion factor comes into play because it's a fixed pot. So if you're trying to all of a sudden create more, it has to come from somewhere. And so it's at the expense of other existing procedural codes.
Exactly. And Medicare has a threshold for this. It's $20 million. So if any change would increase or even decrease overall Medicare physician spending by $20 million, then that triggers CMS having to, in a compulsory way, make adjustments to maintain budget neutrality. And so you can use some round numbers, like if Medicare physician payments, if you're in your base case, were $100 billion, and then a new procedure came on the scene, got a billing code, and RVUs associated with that, times the conversion factor were, let's say, 40 million in new expense, this would require then Medicare to respond by a 0.04% reduction in the conversion factor. It's obligatory. And what I've always said, and what I told you, Amar, in preparation for this episode, is that this idea that medical progress goes forward, that new value is created, and as a result of that new value being created, everyone else has to take a haircut. In other words, that the pie is fixed. My feeling is that is so irritating to physicians because it is an un-American idea that the pie is a single size and that it can't be grown. That's just not how anything else works in the U.S. economy.
No, it's very true. And it creates this, and it probably was generated to do this on purpose. It creates this infighting amongst the different specialties because you have to kind of rob Paul to pay Peter or something.
That's right.
And
Yeah.
and so, like, as you and some of the listeners may know, I'm one of the RUC advisors for our specialty. So I sit at this meeting that's held every year, where these RVUs are decided. And you're talking about your codes for your specialty, and you know that it's so critical, because trying to convince the people at the table to give you any RVUs is very tough, or even maintaining existing RVUs, because they know that it's going to be at the expense of their specialties. And so it's very it's almost like a little bit of a Game of Thrones kind of environment,
Exactly.
where,
Yeah, I was thinking the same thing.
yeah, because everyone's trying to jockey for position to make sure that their specialty is not affected. I mean, just like what you see happening with politicians with pork barreling. Like, if money's coming in, everyone wants to get something. Here, if money's potentially losing, nobody wants to be the one losing the money. So
Sure.
yeah. But I did want to kind of segue with like some of the reasons we're seeing this recently. So one of the things, as we talked about, is like new procedures, right? So whether, high expense procedures are going to have high valuation. So whether they're in fields that have high equipment costs or labor costs, then that would cause adjustments to the conversion factor. But another thing in the last several years that's happened is there's been this push, which is a good push, to compensate primary care appropriately, because the worry is that there's less people going to primary care. There's a lot of physician burnout, and the compensation, because it's not procedural, is lacking, right? So to bump up primary care, they adjusted the E&M codes, which is the codes for consultations and follow-up appointments, which is the bulk of what primary care does. And they also adjusted staffing pricing for nurses. And so when all this increased in the last few years, anybody who's in a procedural specialty, surgical specialty, oncology specialty, radiology, they all saw that the way the conversion factor hit them is it caused cuts. And so this is the reason, like, when I talk to my physician friends and all the other specialties, they're always like, this is Biden's fault. This is Trump's fault. I'm like, no, this is legislation that's been around for decades, that you can't even help primary care without taking it from procedural, because it's a budget neutrality.
It's funny you mentioned that, because I've had the exact same conversations with people assigning blame here or there, but they really don't have a good grounding in how the system works, and that creates this frustration once again. An interesting thing, you and I didn't really have this as something to cover in the episode, but as you were talking, I was thinking, we see the situation, the physicians in greater and greater numbers employed rather than in private practice. And that's a whole separate episode we could talk about in detail, those trends there. But if you look at the Medicare physician fee schedule, and the fact that certainly, even if the number today, 30, next year, $32.35, even though that's $1 and change more, once again, than it was in 1992, when it was $31, in real terms, that is a massive cut, huge. And so if you look at the way Medicare pays for things, there's the Medicare physician fee schedule on one side, which we're focusing most of our attention on here. But then there's the HOPS rules, the hospital outpatient department, which are facility billing. So that's, again, another topic. But so you have professional services on one side, you have facility services on the other, and facility payments, which are meant, obviously, to go to the owner of the asset. And so what we've seen over time is, because the professional reimbursement hasn't kept up with costs, and it certainly hasn't caught up with the value of physicians on a supply and demand basis, is that hospital systems are subsidizing to greater and greater extent the physician to arrive at a competitive overall compensation package. And so if you're listening to this as a hospital CFO or hospital finance leader, this is the dynamic, of course, that gives you heartburn. It's unavoidable. It is in many ways Medicare's fault, but it's just something to be aware of, that this is an underlying dynamic in the U.S. healthcare system.
100%, Anthony. And it all kind of feeds into each other. So physicians in private practice, because they're concerned about the instability in future payments, right, and being able to budget appropriately and maintain their practice due to these declining reimbursement, will choose to sell their practices to hospitals, or more so even to large corporations and private equity, who then salary these people. And to encourage them to sell their practices, they set very high salaries for these individuals, which then the hospitals have to be competitive and attract talent as well. have to also pay those similar salaries, but they're once again not getting paid for those services through the physician fee schedule, which is creating this whole issue now with decreasing margins and hospitals and having to shut down entire service lines in some aspects and shift costs of sites of care and everything. Many episodes.
Oh my God, exactly. And that's, the hospital system financial performance, in my view, is substantially impacted and substantially sort of baked in one way or another, i.e. baked in very low. Your operating margins are going to be low if you're in an environment where government payers, Medicare and Medicaid, make up a huge portion of your payer mix. And you're going to run up against reality. You can try to play games, you can try to do this, you can try to do that, but the headwind that you face is not the same headwind in some of these booming geographic areas in this country where there's so much inflow of new residents. Those people are moving there because jobs are there, which then means they are commercially insured. That is a tailwind of a substantial nature that it results in, I'm talking 3-4 percentage points difference in operating margin. And, you can find yourself as a happy, lucky CEO in a boom town with north of 5% operating margins, or you could be the second coming of, I don't know, the greatest manager that ever lived and find yourself with 2% operating margins if your climate is just difficult.
Yeah. Or flat margins. Yeah, exactly. No, this is the struggle right now in healthcare across the board. Pivoting back, I think, a little bit, let's talk a little bit why MACRA maybe didn't fix this and why these doc fixes have to happen at the end of the year. So a lot of it has to do with the cycle of how this all rolls out. So CMS proposes a new physician fee schedule that comes out, the proposed rule, in July. And then there's a comment period, people submit, and then the final rule comes out in November. So which is why when the final rule comes out, which has this new conversion factor, it's a mad rush in November and December to get this quote unquote doc fix in any legislation to once again, kick the can for these cuts down the road. And so that's why that the timing is when it is. And MACRA, which was supposed to fix it, because it just had stable, stable set rates of 0% or 0.5% for certain years, wasn't able to adjust anything because of the budget neutrality. So you still end up with these cuts.
Yes. And that's where we are right now. So, as the year marches through towards the middle of the year, CMS releases an initial proposed rule. It includes RVU changes. It includes a conversion factor changes, all taking into account the budget neutrality requirement. There's a comment period where all the different stakeholders in healthcare for about 60 days time are allowed to make comments. CMS reviews them. CMS often doesn't make large scale changes, by the way, as a result of this comment period. And then, as I alluded to in my little line that I mentioned at the beginning of the episode about November, then the beginning of November comes around and then CMS drops the final rule. And that leads us to now. We're in December. And of course, the final rule makes everyone unhappy. Congress realizes it's ridiculous. Congress, in a short period now, in the lame duck session, tries to get its act together to pass a fix. They're talking about it as we speak, a 2.5% fix, which would leave a 0.3% haircut, by the way, but no big deal. I guess that's, change lost in the couch cushion. And so that's where we are at the moment.
Yep. And what's interesting about it is some of the long-term considerations. And I thought maybe, Anthony, you could talk a little bit about like how this, and this kind of ties into what you were almost talking about a little earlier, how the market dynamics come into play here and cost shifting and to account for some of this.
Sure. So earlier, we were talking around the reality that, inflation marches forward, costs march forward, both as it relates to personnel costs, supply costs, number of different, what it takes to run, say, a full service hospital system. And reimbursement through the Medicare program has not kept pace with those costs. So much so that right now in the United States, at least on average, for every dollar that Medicare reimburses, on average, hospitals cost to get that dollar is about $1.20. So that's a pretty substantial difference. Some systems run a little bit leaner, some systems a little bit less lean, but $1.20 per every dollar Medicare reimbursement is a pretty good average number. And so over time, though, that difference has grown. That loss has grown for hospital systems. And so when they sit down, on the provider side, hospital system, multi-specialty physician groups sit down at the negotiating table with the commercial insurance company to re-up the contract, the physician side of the table has to up the ante on what they recover in the contract with the commercial payer in order to keep the lights on, in order to make up the gap from the government payers. We spoke about Medicare just a moment ago, but Medicaid's even worse math. And so over time, that's resulted in increasing premiums, increasing inaffordability of health insurance for many Americans, and therefore a decrease in access to care as people decide on the margins, well, you know what, maybe I don't need coverage, or maybe I'll just get Medicaid then. And so it's resulted in a kind of a contraction in the commercially insured population nationwide.
Yeah, no, exactly. And to flip your statistic the opposite way, just to hear it both sides. So pretty much Medicare pays about 84 cents for every dollar of cost of care, right? And so
sure,
let's say if your payer mix for your patients was, 40% Medicare and 60% commercial, you might need almost 100 to 150% on the commercial rates to cover for that Medicare loss. And big health systems can negotiate like this, but small health systems don't have the leverage and can't. I'm in one of those smaller health systems, and it's very tough to get higher payments on the commercial side, which is why you end up struggling as a smaller community hospital. And then just like you said, Anthony, that when the commercial rates are going up, they just pass it on to the consumer in terms of premiums, which then just feeds this vicious loop, and it impacts actually whole sometimes service lines that hospitals may offer, right? Something that's not profitable, they'll decide not to offer it because they just can't cover their costs.
That's right. Or they'll offer it if you have multiple locations. Let's say you have locations that are inner city locations and then suburban locations. You might consolidate the services in the more challenging financial environments, the worst payer mix environments, and then maybe reinvest or just shift those services to environments where the payer mix more shifts towards the commercial.
Well, I guess, is there a summary we can give our listeners and viewers from all this? So we're not happy because it's not about the money. It's not about the money. It's the lack of input, voice. It's the lack of stability. Imagine any other person who's their entire, what they do and is all based on somebody else having to suffer, and it feels bad that for you to have stable payments, it means you have to take it away from another person who's working hard.
Yes, it's a fundamentally unsatisfactory, as you say, Game of Thrones type trade-off that pits one specialty against another. And to be very clear, that's not a natural way for physicians to think. Every day, in the part of my week anyway, where that's patient care, is I see the world in what are all the departments, all the services, all the units, all the individuals that we need to bring to bear to provide a seamless, integrated experience of care for the patient. I personally don't see the world through an oncology lens versus a neurosurgery lens versus a thoracic surgeon lens. I see the world through a lens of this patient has lung cancer. These are all the services they need. And the pulmonologist is not more or less valuable than me as an oncologist. The thoracic surgeon is not more or less valuable because all of those services must be delivered, or it's not a complete product, is it?
No.
And so
100%.
It doesn't jive with the way the world actually works.
And I think another thing to take away from it is for patients to get good care, they also need to have support services, right? Like social work, nutrition, so many other things that Medicare doesn't compensate for appropriately. And so it's the payments that doctor practices and hospitals get from physician services that pays for all this other stuff. And so that's one of the first things that end up getting cut. So when these reimbursements go down, it's not that all of a sudden they're going to just stop doing surgery. It's that they're going to, affect all the stuff that allows for patients to have good quality, personalized care. And that's what gets cut.
And that's really where my thoughts go quite often. And that is the individuals and the families who are less well off, who are less in a position to just handle it, to handle the adversity that comes with being sick, right? Those are the people who suffer the most. We spoke about it back when we went through our Medicare, the traditional Medicare versus Medicare Advantage episode. All the hijinks, all the badness that comes on the Medicare Advantage side ultimately hurts the senior who has difficulty paying their bills because that's a senior who's more likely to sign up for Medicare Advantage. And the same story here. Every once in a while, I have these patients who have things so in order in their lives and such great support from their families. And they're very, obviously, they're well in general, besides this sort of one cancer problem. And those individuals seek no services, right? If we risk stratified them, they would be stratified to the lowest risk possible. And for every patient like that, though, there's 4 or 5 who need substantial wraparound services to make it all happen.
Exactly.
And yeah, we finance that through physician work. There's been the emergence of some codes like oncology navigation codes, so-called principal illness navigation and things. And those are helpful, but they are not particularly helpful against a headwind of substantial cuts in physician payments.
Exactly.
Because then those are just going to be pennies on the dollar.
No, I think that's very important. And so I think the bottom line for our viewers to understand is that, we are concerned, obviously, as physicians of the doc fix and all these issues around payment stability, because it does impact patients and it impacts access to care and all these other critical aspects of making sure like patients can get the care they need close to their home.
That's right. And I'll close the episode in saying that one of the reasons why, Amar, you and I decided to make this podcast is because you and I, and you even more than me, I'm so impressed with your portfolio over the years of volunteering that you've done in health policy and healthcare finance realms. But we are actively engaged to try to prevent, forestall, delay decisions that hurt patients in the manner that we've talked about in this and other episodes. That's why we do this. We just happen to decide at a certain point that, well, why don't we jump on the bandwagon of putting content out there so we can try to take what we know outside of these little small circles that we often, let's say, find ourselves in and make it digestible and understandable for those who might have interest in learning more. So we hope you'll stay with us as we continue this journey, and we'll come back in a couple of weeks with episode 6.
Sounds good. Have a happy holidays, everybody.
We'll see you then. And same to you. Safe travels.